So a standard transthoracic echocardiogram protocol, looking at all the images obtained in a standard echo, not in a patient with any particular pathology, but rather to look at the four kind of standard windows that we use, the different views that we can obtain from them, what that information can tell us. To begin with, on the parasternal windows, the probe is placed on the patient's left sternal edge in intercostal spaces, starting high and then moving down until an image of the heart is obtained. Probe marker is pointed towards the patient's right shoulder. And so on the right of screen, we actually see the apex of the heart, and on the left of screen, we see the base of the heart. The probe marker on the screen indicates the side that is pointing to the patient's right shoulder. Down the bottom of the screen, we can see the echocardiogram, which gives us some information about the cardiac cycle. And in this deep view, we're actually looking not at the cardiac structures, but at those structures behind the heart. And the aorta is a good reference here, the descending aorta, which can help guide us for a pericardial effusion, which might lie anterior to the aorta, or a pleural effusion, which might lie posterior. The parasternal long axis at a shallower depth now, so that we're focusing on the cardiac structures. We can look for a anterior pericardial effusion, but the typical structures that we see is the right ventricular outflow tract, the left ventricle, and the left atrium, separated by the mitral valve, and then the aortic valve with the left ventricular outflow tract not marked on this picture. If we freeze that image, we can take some measurements of the intraventricular septal distance, the left ventricular internal diameter in diastole, and the left ventricular posterior wall dimension. We're now just zoomed onto the aortic valve itself, so that we can see the non-coronary cusp lying closest to the probe and the right coronary cusp lying more posteriorly. This image just allows us to interrogate the valve movements, the thickness of the leaflets, and to look for any obvious thickening or abnormal movement of leaflets. We can freeze and in mid-systole measure the left ventricular outflow tract dimension, diameter, which allows us later on to figure out the cardiac output. And we can freeze in end of diastole to measure the sinus of Valsalva here, and the sinotubular junction a little bit further in. And can we compare these to standard measurements for patients? This is a color flow Doppler image now across the aortic valve, and in color flow Doppler, we are seeing the velocity of blood flow represented as color, either being red, which is movement towards the probe, or blue, which is movement away from the probe. The blood flow in this case across the aortic valve is neither towards nor away predominantly to the probe marker, and so there's a mix of colors. But there is no obvious jet of flow emanating from the aortic valve at any point in diastole, which would represent aortic regurg, and there's no narrowing of the aortic valve opening that would lead to a stenotic turbulent flow. This is a view of the ascending aorta, and this is obtained usually by moving upper rib space from the previous images. This is a frozen image of the ascending aorta, which allows us to make a measurement which we can again compare to standard values. And now we're just returning to the same parasternal long axis view, but we're now zoomed on the mitral valve. And again, this allows us to look at the thickness of the mitral valve leaflets and their movement to look for any pathological movements. Color flow Doppler over the mitral valve. Now shows us that when the mitral valve is open, there is predominantly red flow through that valve, as that flow is predominantly moving from the atria up to the ventricle and therefore towards the probe marker. And we can see a very small blue jet of regurgitant flow during ventricular systole in this region, which signifies a trivial amount of mitral regurgitation. Still in the parasternal long axis view, but with the probe panned inferiorly so that the beam of the ultrasound is actually moving down towards the patient's feet and away from their head. This gives us a view of the right ventricular inflow and specifically the tricuspid valve. So closest to the probe is the right ventricle. This is the tricuspid valve between, and then the right atrium. Here we can look for any regurgitant flow across the tricuspid valve. Again, flow towards the probe marker is red and away from the probe marker is blue. In this case, there's only the very tiniest amount of trivial tricuspid regurgitation that can be seen as a small blue jet in the middle of the tricuspid valve during ventricular systole. This is a spectral trace continuous wave Doppler across the tricuspid valve. We can see on the top of the screen that we have the reference image, which shows the line of interrogation of the continuous wave Doppler. And on the spectral trace itself, we can see in the horizontal axis that we have time. At the bottom of the screen, the electrocardiogram, giving us reference to the cardiac cycle and different phases of that. On the vertical axis, we have the different blood flow velocities that are being measured along the entirety of this line of interrogation. So there are blood flows that are occurring towards the probe, above the baseline, and there are blood flows that are occurring away from the probe, and they are plotted below the baseline. We can see areas of increased density, and that just signifies that there are more signals returning that particular blood flow velocity. There is no reference to where these velocities are occurring along the line of interrogation, and so we need to use our anatomical knowledge, and that makes the continuous wave Doppler useful for applying the line of interrogation across a known orifice so that we can surmise that maximal velocities will be present across that narrowing of the orifice. In this image there is only trivial tricuspid regurgitation and not an adequate signal there to really make an interpretation of the pressure gradient across the valve. This is now still a parasternal long axis view, but we've now panned superiorly instead of inferiorly, so the ultrasound beam is now being moved towards the patient's head, away from the toes, and this allows us a view of the right ventricular outflow and the pulmonary valve specifically. So again, at the top of the screen is now the right ventricular outflow tract. The pulmonary valve lies between that and the main pulmonary artery, which moves down towards the bottom of the image. This can be interrogated with color flow Doppler, and color flow Doppler here is often useful to identify the exact location of the pulmonary valve, which can be sometimes difficult to see. In this instance, we can see predominantly during systole is blue laminar flow throughout the right ventricular outflow tract and down into the main pulmonary artery. We can just see two small flashes of red which represent some trivial pulmonary regurgitation and also helps us to locate where the pulmonary valve is in this image. This is another spectral trace now looking across the pulmonary valve and down the right ventricular outflow tract and main pulmonary artery. However, in this spectral trace, we are using pulse wave Doppler as opposed to continuous wave Doppler that was used in the image a couple of slides previous. The difference between pulse wave Doppler and continuous wave Doppler is that in pulse wave Doppler, we are not interrogating all of the blood flow velocities along this line of interrogation, but we are only interrogating those blood flow velocities that are occurring between a small gate, which is marked just behind the highlighted point here. A little bit hard to see on that image, but we are not actually, we're discarding all the data proximal to that gate and all of the data distal to that gate. And we have control of where we set that gate. So in this case, we've set that gate just in the RV outflow tract. And therefore we can be more specific about which velocities we're trying to interrogate along this line of interrogation, as to be those velocities only within the anatomical boundaries of where we set the gate, in this case in the RV outflow tract. Tracing the spectral Doppler allows us to calculate the maximum and mean velocities as well as the pressure gradient in the RV outflow tract based on those velocities that are occurring there. We can also use this information to figure out the velocity time integral, and if we can find an adequate window to accurately measure the RV outflow tract, which is not always possible on transthoracic imaging, then we could calculate the cardiac output for the right ventricle. And a similar but different spectral Doppler trace through the RV outflow tract in the pulmonary valve, this time using continuous wave Doppler. So remembering that with continuous wave Doppler, we are picking up all of the signals along the line of interrogation, not just the signals in the gate that we were looking at on the previous slide where we used pulse wave Doppler. So in continuous wave Doppler, where the line of interrogation includes the RV outflow tract as well as the pulmonary valve, we can anticipate that the maximum velocities are going to be occurring at the point of the valve, which should anatomically be the narrowest orifice along the lines of the interrogation. And we would anticipate that the maximum velocity would be higher in this continuous wave Doppler, and it is at 1 meter per second, as opposed to 0.8 meters per second on the pulse wave Doppler, which was measuring the velocity in the RV outflow tract proximal to the pulmonary valve. And so with this information, we can make some inferences about the pressure gradient across that pulmonary valve. And again, this is a continuous wave Doppler image, essentially looking down the same tract of the right ventricular outflow. But you can see that the spectral Doppler trace baseline has been moved down, and the actual alignment of that beam has probably been altered slightly to try and interrogate for any significant pulmonary regurgitant jet. So we're now looking with more interest at flow above that baseline back towards the probe and looking for any significant regurgitant jet to signify a more significant pulmonary regurg than the anticipated trivial regurg that was thought to exist based on the color flow Doppler. And there's no signs of any significant regurgitant jet there on the spectral trace either. Moving now to the parasternal short axis images, the probe is positioned in the same position as it was for the long axis view, but the probe is now rotated 90 degrees clockwise. And this obtains us a view of the aortic valve in cross section, which is present in the middle of the screen. And then the chambers of interest that surround that are posteriorly the left atrium, the intraatrial septum, separating that from the right atrium, then the tricuspid valve separates that from the right ventricle. We can just see some of the pulmonary valve separating the right ventricle from the right ventricular outflow tract. This is now a zoomed view on that aortic valve, and this is a useful view for looking at the thickness of the leaflets, the opening of the valve, and the right coronary cusp lies closest to the valve, closest to the probe, the left coronary cusp and the non-coronary cusp. Color flow Doppler now over the aortic valve. When the blood flow is moving in from behind the screen towards you as the viewer, then obviously that flow is not moving directly away or towards the probe marker. And so conceptually, what I think is most useful when looking at color flow Doppler in this scenario is that you can see that when the valve is closed during diastole, there's an absence of color flow, signifying that there's no regurgitant jets occurring. With a slight rocking of the probe, we can move our focus to the main pulmonary artery, and in fact even see the right and left pulmonary artery bifurcation, as well as see the pulmonary valve again. And we can interrogate this with color flow Doppler, and again we see that trivial pulmonary regurgitant jet as a small flash of red flow which is occurring towards the probe marker. But predominantly we're seeing during systole blue laminar flow down the pulmonary artery. Again, we've used continuous wave Doppler here to interrogate the blood flow velocities along that pulmonary outflow and across the pulmonary valve. And it's important to do this from different angles where that opportunity exists, as some regurgitant jets may not be visible on all views. Rocking back the other way, we just get a more focused view of the tricuspid valve, separating the right ventricle and atriums. And again, we have color flow, with the red flow being towards the probe and blue flow being away from the probe. We can see some tricuspid regurg emanating from the middle of where the tricuspid valve sits, and we'll interrogate that further with the spectral trace. And here you can see that we're interested in the flow that's occurring away from the probe, with the baseline set high on the screen and cutting off some of the spectral trace that occurs higher up. We can see these spikes that are occurring on the spectral trace, and these actually aren't representative of blood flow velocities, but are in fact representative of valve leaflet closure and opening. We can see an incomplete tricuspid regurgitant spectral trace below the screen, below the baseline, apologies, which means that, and occurring during ventricular systole. So that gives us the information that there's this regurgitant tricuspid jet, but if it was complete, it would be filling out a complete dome shape, and it's not doing that. So that's suggesting that this is a trivial to mild tricuspid regurgitation based on spectral Doppler assessment. A slightly zoomed in view looking at the intraatrial septum for any abnormalities, anatomical abnormalities that may occur at that location. And now color flow Doppler interrogating the intraatrial septum for any defects that might be allowing the shunting of blood, usually from the left to the right. And now the short axis view, where the probe is panned down along the heart from base towards apex to the mitral valve level, and we can see the anterior and posterior mitral valve leaflets within the left ventricle, which looks like a circular donut shape, with the right ventricle piggybacking up on the side. At this level, we can utilize the left ventricular segments to interrogate for any regional wall motion abnormalities. We can look at color flow Doppler on the mitral valve, and again, this is a slice where flow is moving from the viewer's perspective into the screen and away, and so we'd be looking to see any eccentric regurgitant jets occurring in this view. Moving down below the level of the mitral valve now to the papillary level. This is just another short axis view which makes a cut slightly further down the left ventricle towards the apex, and we can see the papillary muscle attachments, both posterior medial and anterolateral. And again, this is a useful view for interrogating for regional wall motion abnormalities in the relevant segments of the left ventricle. And now right down to the left ventricular apex, again for further interrogation of segments and to see that there's no ballooning of the left ventricular apex. Color flow at this location allows us to confirm the presence of flow within that ventricular cavity, which helps us to exclude an LV thrombus. We move to the apical window now, and first off the apical four-chamber view. This view is achieved by placing the probe usually in the fourth, fifth, or sixth intercostal rib space, moving from the mid-axillary line around the patient from lateral to medial, with the probe marker facing towards the patient's left shoulder. And the four-chamber view shows the left and right ventricles and the left and right atria below them, separated by the mitral and tricuspid valves. We can interrogate for regional wall motion abnormalities in this view of the lateral walls and the septal walls. This is a freeze image at the end of systole, which helps and allows us to measure the left atrial area. And likewise, at the end of systole, we can measure the right atrial area. And we can compare these measurements to standards for patients to look for atrial enlargement. Color flow Doppler across the mitral valve, again looking for any regurgitant flow. And we can see some very trivial mitral regurgitation, which on the previous slide was shown as a slight blue fleck during ventricular systole. And we can see on the continuous wave spectral Doppler that there's an incomplete mitral regurgitant jet. If that was a complete regurgitant jet, this would be a complete full spectral trace. A zoomed view on the mitral valve leaflets, which we have done already, but again, this is a different view, so it's useful to look for any abnormalities or pathologies that might not be visible on all views. And so we can see the anterior and posterior mitral valve leaflets. And then just some color flow over that zoomed image shows that very small amount of blue flow, signifying some very trivial mitral regurgitation. This is now looking at mitral inflow using pulse wave Doppler as part of the assessment of diastolic function. So a pulse wave gate is set up at the tips of the mitral valve, and we're interested in the flows into the ventricle, particularly during diastole, ventricular diastole. And we can see the early flows and then the atrial kick. And by measuring the E velocity and A velocities and measuring the ratio between them, we can use that in our assessment of diastolic function. This is the color flow Doppler, which is set up to identify the pulmonary vein flow. Which we then use to pulse wave to measure the pulmonary vein velocities. And this is again useful as part of the assessment of diastolic function, which I'm not going to go into the details of, but we can see that there's a systolic and a diastolic pulmonary vein velocity, as well as a atrial reversal. And we can use these numbers to make assessments of diastolic function. More diastolic assessment now with tissue Doppler imaging. So previously we were using Doppler to assess blood flow velocities. Now with tissue Doppler imaging, we're looking at tissue velocities, which are actually much lower than blood flow velocities. And we've got a pulse wave sample gate, again, over the mitral, the medial mitral valve annulus. So we're actually interested in the velocity of muscle contraction and relaxation at that point. And the mitral valve annulus tissue velocity in relaxation gives us some information about diastolic function. We do that at the medial site as well as at the lateral site, and the combination of those values with the information obtained from the mitral inflows again is helpful in making assessments of diastolic function. While we've got the tissue Doppler imaging mode active on the echo, we'll often measure the the lateral tricuspid valve annulus tissue velocities. We're actually looking not in the diastolic measurements, which would be those measurements in the last two slides, but now we're looking at the systolic function of the right ventricle. And the RVS prime gives us information about the longitudinal right ventricular systolic function. This is now an RV focus view, so we've repositioned the probe slightly to get a better view of the RV, and we can see the anterior and septal tricuspid valve leaflets. We can use color flow Doppler to interrogate the tricuspid valve again from a new angle, and we can see that trivial blue flash of blood flow away from the probe marker, which signifies tricuspid regurgitation, but in this case only trivial. And again, we can use continuous wave Doppler to interrogate that and measure the tricuspid regurgitant jet velocity, maximum velocity, which allows us to estimate the right ventricular systolic pressure after we've made an estimation of what right atrial pressure is. Because the velocity across the valve we can use to calculate the pressure gradient between the two chambers. So if we can make an estimation about right atrial pressure and then measure the velocity across the tricuspid valve, we can then make an estimate of the right ventricular systolic pressure. A slightly more focused RV focused view at a shallower depth. So we're looking specifically at the right ventricle now and maximizing the view of that chamber. With that enhanced view, we can freeze the image and make some measurements of the diameter or dimension of the left ventricle at the basal and midpoints. And now we move to that apical 5 chamber view. So this is the same window as we obtained the apical 4 chamber view, but we now just tilt the probe anteriorly slightly, so the beam of the ultrasound is moving slightly towards the patient's feet and away from the head, and that opens up the aortic valve, which is marked. And we can then use color flow Doppler to look for any regurgitant jets across the aortic valve. We can also use pulse wave Doppler at the level of the left ventricular outflow tract, so just proximal to the aortic valve itself, and then at that point measure the blood flow velocities using pulse wave Doppler, which allows us to measure the maximum velocities, but also to calculate the velocity time integral, which in conjunction with the measured left ventricular outflow tract dimension that we measured earlier on our parasternal views, allows us to calculate the cardiac output by way of measuring the Doppler stroke volume, and then utilizing the heart rate measurement multiplied by the stroke volume to figure out cardiac output. We also measure continuous wave Doppler across the aortic valve, which, because we anticipate or make the assumption that the velocity will be actually highest at the narrowest point, which will be at the point of the valve opening, not at the left ventricular outflow tract, but at the point of the valve opening. We can, having measured the left ventricular outflow tract diameter and knowing the velocities at that point that we obtained from the previous pulse wave Doppler imaging, now using continuous wave Doppler and finding the maximum velocity, which we assume will occur at the point of the aortic valve itself, we can use the continuity equation to calculate what the aortic valve velocities, pressure, and area will be. This is the continuous wave Doppler with the baseline moved down, so we're looking here for any regurgitant flow, and there is no significant regurgitant jet present in this slide. And now we're just looking at a more focused left ventricle view, which will be used for our later calculations of ejection fraction or left ventricular ejection fraction using Simpson's method. We usually do that twice to better allow ourselves to obtain some good views with good endocardial definition, and to reduce the risk of error from having misaligned views or foreshortening. And then we move to the apical 2-chamber view. So the probe is in the same position as it was for the 4-chamber view, but the probe marker is now rotated 90 degrees, approximately 90 degrees anti-clockwise, so that it's now pointing towards the patient's head. And in this view, we're again LV focused, so that we can use this for endocardial definition, so that we can use Simpson's method with biplane or two orthogonal views, so the 4-chamber and the 2-chamber, to calculate the ejection fraction. Now, just with a bit more depth, we can see the kind of true apical 2-chamber view, which shows us the left atrium and the left ventricle separated by the mitral valve from a new view, which allows us to look for any pathology that might exist on the valve. And this gives us a view of some slightly different left ventricular segments. Namely, we're looking at the anterior walls and the inferior walls. So anterior and inferior. We can measure the left atrial area again in the 2-chamber view, so that we have orthogonal views with the 4-chamber for measuring left atrial size accurately. And we can interrogate the mitral valve again with color flow, because again we might be finding that a regurgitant flow may be occurring which is only visible on one view, or we may be getting better alignment on one particular view of a regurgitant jet that we might actually see from other views as well. But our best alignment will give us the most accurate information about the velocities that are occurring across any orifice. And again, we're looking at continuous wave Doppler here of the mitral regurgitant jet, which is again just trivial. And now we move to the apical 3-chamber view. So this is a further approximately 45-degree counterclockwise rotation from where we had ended up on the apical 2-chamber view. And as we can see on the screen, we're now seeing the left ventricle separated from the left atria by the mitral valve, and the aortic valve with the aortic outflow. This is in some textbooks is called the apical long axis view, and you can see the analogies between this view and the parasternal long axis view. We can interrogate with color flow across the mitral valve again, and again use continuous wave Doppler to prove that we've only got a trivial regurgitant jet across the mitral valve. And we can now also look at the flow across the left ventricular outflow tract and across the aortic valve with color flow. And this is a zoomed image of the same. And again, continuous wave Doppler. This is now with the baseline low, looking for regurgitant flow back towards the probe. And there is no significant aortic regurg present there. But again, useful to interrogate the aortic valve from this angle, even though we've already interrogated it from a number of other views. There can be cases where regurgitant jets may not be visible from other views, but may occur on subsequent views. And we've also done LV focus views in the apical 3-chamber. To allow us to interrogate for regional wall motion abnormalities. And then this is just a shot of the very LV apex, which sometimes is easiest to achieve when the probe is positioned for the apical views rather than for the parasternal views. Just measuring Simpson's biplane now to calculate the ejection fraction. So this is the measurement of the LV at end diastole in the forechamber, end systole. So using Simpson's method to compare the size of that chamber during systole and diastole, we can make estimations of the ejection fraction. And then by incorporating the two chamber views at diastole and then again at end systole, we can now use Simpson's biplane method to estimate the ejection fraction, which in this case is 60% normal. Moving now to the subcostal views, the probe is placed below the ribs with the probe marker pointed towards the patient's left shoulder. A view of the heart is obtained with the liver lying anteriorly, and then the four chambers of the heart on view with the right atrium and right ventricle sitting closest to the probe, and the left atrium and left ventricle sitting further away. This is a useful view for looking for pericardial effusions, as well as interrogating the intraatrial and intraventricular septums. Color flow Doppler has been applied across the intraventricular septum here, looking for any intraventricular septal defect. And now a zoom color view across the intraatrial septum, looking for any intraatrial septal defects. By rotating the probe so that the marker is pointed towards the head, or the 12 o'clock position, we can obtain a view of the inferior venous cava as it drains into the right atrium. And of note, the ultrasonographer has captured a number of cardiac cycles here, 4 cardiac cycles rather than the standard 1 or 2 cardiac cycles, and that is to incorporate the patient's respiratory cycle into the imaging so that we can see the collapsibility of the IVC in this image. We can also freeze and measure the IVC diameter, in this case normal at 1.65 centimeters. And then we can use color flow Doppler to identify the hepatic vein, in which blood flow should always be moving away from the probe marker and therefore be blue. But in cases of significant, usually severe tricuspid regurgitation, there may actually be retrograde hepatic vein flow, so that there may be a flash of red blood flow up into the hepatic vein. We interrogate that hepatic flow further with pulse wave Doppler, again looking to see that flow is predominantly occurring below the baseline and that there is no retrograde flow occurring in the hepatic vein, which would signify significant severe tricuspid regurgitation. Lying slightly medial to the IVC, we can identify the descending thoracic aorta, abdominal aorta, and see the pulsatile blood flow within it. And we can use pulse wave Doppler to interrogate that blood flow. In cases of severe aortic regurgitation, there can be retrograde flow occurring in the abdominal aorta. The subcostal window also allows an opportunity for some short axis imaging of the heart, and in this case, the aortic valve at the level of the short axis images at the level of the aortic valve. This can be particularly useful in patients where subcostal views are difficult to obtain. In this view, a different orientation, but still looking at the intraatrial septum for intraatrial septal defect. And in short axis, now at the level of the mitral valve, we see the left ventricle posteriorly and the right ventricle lying anteriorly. Pan down now beyond the mitral valve level to the level of the papillary muscles, and we can make some visual assessments of LV function and the size of the two chambers relative to one another on this view, particularly again if the parasternal views are inadequate. Finally, we're looking at the suprasternal windows, and these can be used to interrogate predominantly aortic flows. In this image, we can see the ascending aorta, the arch, and then down into the descending aorta. We can look at colour flow Doppler across them and expect to see nice laminar flow away from the probe in the descending aorta. And if we look at pulse wave flow in the descending aorta, we are looking for an absence of significant aortic regurg, which would be represented by flow towards the probe. Continuous wave Doppler in the descending aorta is really looking for any flow accelerations which may exist in pathology such as coarctation of the aorta. And so significant flow velocities in the descending aorta would trigger concerns about coarctation or other stenosis in the aorta. And that's 97 slides later, the end of the presentation. Thanks for your attention.